inquiries. Gonna put that up there. So there's a link there for anyone that's got any media inquiries, and our syphilis website, which has a wealth of information that we've collected since we announced this outbreak response a little over a year ago. And with that, I'm going to get into it. So here's a quick visual of where we are with the syphilis data trends. There is always a little bit of a lag. You see that kind of dotted line. But ultimately, the message I want to get across here is this is what we were hoping to see since we announced. If you can see, July of 2023 is when we formally announced it, and what we wanted to see, you always, a little bit of an increase is a good thing. We were doing more testing, we were finding more cases, but ultimately what we want to see after that is a downward trend. And these are some kind of color-coded thresholds we have. Originally, we were basing our baseline off of 2019 numbers, and that was to essentially control for any confounding COVID effects. But as we completed the course of a full year, we started looking at the 2023 baseline, and this is exactly what we were hoping to see. Now, what happens here is we appeal to leadership. We say this is what we're looking at. It'll be up to the powers to be to officially declare an end to the outbreak. But we like the numbers we're seeing, and what this means going forward. We're still going to be doing a lot of the same things that we've been doing. So what that's going to look like is we're still going to be doing monthly threshold analysis and meeting regularly, monitoring the case levels and communicating with leadership. Our disease investigation and public health follow-up folks that have been so wonderful are continuing to do what they do, which is get out there and try to intervene. They're identifying, notifying, referring persons with indication of syphilis, and trying to elicit their partners as well. They will continue with the training that they've been doing. They will collaborate with the outbreak management team to make sure that we stay ready if the numbers ever do start to take an uptick again, and continue to monitor and assess their practices. Similarly, our outreach and education team are going to continue to do their community education as requested, raising awareness and connecting people to clinical services. They'll continue to support monthly screenings and provide collaborative testing and condom distribution events. And what that means for my area, which is community involvement and mobilization, is we're going to keep doing these town halls. This is kind of the first iteration where we start to open it up, hence the DoxyPEP. But we're looking to expand to more general HIV, STI, and viral hep topics. And oh, by the way, a little shameless plug. Like I said, DoxyPEP was a community demanded topic. So if there are things that you guys want to see, there'll be several points that I include in my email here, but let me know. That's why I usually provide a feedback opportunity, but we very much want to be providing what you want to know more about. So definitely keep me informed, and I will continue to be a liaison for the community and try to connect our internal and external partners and grow what one of my pride and joys, which is the community partner asset spreadsheet that I built. And clinical is going to keep doing their thing. They're going to continue to diagnose and treat. They're also going to continue to monitor and report the clinic supply of bicillin. They did implement a new triage method for the syphilis outbreak response that allowed them to increase client volume and continue to do provider networking, outreach, and education. And on the public information and awareness front, if many of you guys may be familiar with the My Prenatal Promise campaign, and we do have an amazing, both a syphilis provider toolkit and a congenital syphilis provider toolkit on the website. Those are also available in print. Reach out to me and I can connect you with that person if you like some hard copies. But we're doing like a 2.0. There's actually going to be the My Prenatal Commitment campaign coming hopefully right after the start of the new year. And we're going to continue to increase our media presence where we can, not just about our clinic services, but also look to really ramp up presence on social media and dating applications. So that's like the nitty gritty of what to expect going forward. Again, there's our website, and I always throw our provider outreach and reporting contact in there for anyone that needs it. And with that, unless there are any questions, I'm going to transition over to what has been something that I've been intentionally working on for about a year now, and unintentionally working on since we announced this syphilis outbreak response. And that is a policy solution that will kind of help with some of the root cause, perhaps, of this, and hopefully work more on the preventative side of keeping us out of another outbreak. And I want to take a second to kind of recognize how we got here, because there are several people and organizations involved, whether you knew it or not, that led to essentially this proposal that we're looking to pursue. I'm calling it a policy initiative, and that's our very own, first and foremost, Doctors Jeanette Lopez Belin and Mayela Cabrera de Bravo. They are our amazing provider outreach team here. They taught me more than I could ever want to know about syphilis, and also their observations from the field were critical in development of this. Some of the local experts, the Dr. Staffords, Dr. McKinney, Dr. Roche, who really provided some insight into what the service delivery challenges look like in the current landscape. I think I've got some ASTHO folks on here. There was a brilliant publication you guys had. It was also incredibly well timed. I think it was put out about 2 months before we announced our outbreak, but it was the policy considerations around congenital syphilis. And that was really my first indication that Texas is a leader in that we have mandated through legislation the 3 testing points, first trimester, third trimester, and upon delivery. And yet, with all of that, we were 5th last year. We were 4th in case rate for congenital syphilis. So controlling for the population, we obviously had the most cases, but our rate was well up there, well above the national average, despite having those policies in place. Not long after I even plugged that that resource in one of our town halls, and a conversation opened up with a local health department outside of Texas that reached out and said, listen, we want to know how Texas did it. How did Texas get there with the legislative mandate? And I didn't have a good answer at the time, but not only did I want to help them out, I needed to know for my own curiosity. And so I did a deep dive into kind of the legislative history that got us here. And that must be one of my ASTO friends in the chat there. But we got there in a couple different steps, and I'm going to recap some of that. But it was also our incredible disease investigation and public health follow-up extraordinaire, Maria Hernandez, that took me to school on what those policy implementations did for us at the local level and how fundamental they were in developing our program early on. And then I'd also be remiss if I didn't give a brief thank you to the state partners that supported me, and NCSD, the National Coalition of STI Directors, that really helped me put some formalities around this. So ultimately here, the goal is save babies and save money. And I mentioned in 2022, we were 4th Texas was fourth nationwide in congenital syphilis case rate. We were fifth last year, so a little bit of an improvement. And yet you look at like primary, secondary syphilis, we're more like the national average. So there's something we're missing, and this is all in spite of having that legislative mandate. So my proposal was we need to look at increasing provider awareness of syphilis. And oh, by the way, why not other STIs and HIV and the required and recommended screening, treatment, prevention, and reporting practices. Even though that third trimester screening was mandated back in 2015, it became obvious during our outbreak response that it is yet to be universal knowledge. And this is also where I'm going to pause for just a second and say, I'm walking right up to a very fine but a very hard line where my government role is concerned. And so what I have done with this project is try to create all the tools and everything that one would need. I can advocate for this policy as soon as this policy starts to take the form of an actual legislative bill. That is when I have to back down. So that gives you a little insight into my strategy here. But really what I'm looking to do today is to recruit some supportive partners and implementing champions to advocate for this increased provider awareness. And the focus is specifically on syphilis and intervening in the vertical transmission, because again, that's where we see the biggest deviation and where it's the congenital syphilis where Texas seems to be still struggling to bring our numbers down. So the briefest history of all this, syphilis, as many of you know, it's been a public health burden for quite some time now. And around the 1940s, we realized not only is there this amazing thing called penicillin, but it's effective against syphilis. And we've had it almost eradicated before. Now, the other reason I'm focusing very much on the syphilis is because of the nature of the disease. It is known as the great imitator. Because, again, I know I'm preaching to the choir here, but it's difficult to diagnose and often properly stage, which is all critical to treating it successfully. And here's the prior legislative actions I mentioned. So we mandated third trimester screenings back in 2015. Little caveat there, we actually, that legislation also removed the testing for syphilis upon delivery if there was documentation of that third trimester screening. So fast forward to 2019, they reinstated that test upon delivery regardless. So that put us at the 3. And there was also a lot more that went into this 2019 legislation, and I'm going to go deeper into that in a second. But there were more resources, including some research, a newborn screening fund, and some maternal mortality review that went into that legislation. And then, like I mentioned, fast forward to the summer of 2023, and we announced our outbreak here locally. So the proposed solution, it's as simple as this. It's essentially implement a sub-requirement of CE hours around STI and HIV prevention and treatment best practices for providers' relicensing requirements. So currently, medical providers are required every 2 years to have 48 hours of continuing education. And so this wouldn't be over and on top of that. This would be a sub-requirement of those 48 hours, essentially saying, and this is where we're going to open this up for group discussion and feedback. This is where the details I really want to be community informed. But in my mind, I'm thinking, an hour, 2 hours. There was a similar bill introduced in 2019 around opioids. and it's structured slightly differently, but I could see this bill being something similar to that, in that it is, 2 hours for. I want to say they did the first relicensing, and then it's like every 8 years, and so it wouldn't even be for every cycle. Again, the details are less important at this point. But this has been my mobilization strategy around it. So I've developed some resources and tools. I'm going to go into some of those specifics in a second. But looking to recruit some supporters and legislative champions, and then doing what I do as a policy analyst, monitor and evaluate the progress around that, and support ongoing efforts with resources and information. Again, if this starts to take shape, there's a point that I'm not able to speak for or against it, but me, and even including some of my partners at the local and state level, can speak on it, essentially provide further information, but without voicing either support or opposition. And so I touched on the two pieces of legislation that got us there, and I promise I'm about to hush up and turn the floor over, because I want to hear from you all on this. But I also wanted to talk a little bit about what I see as possibly a legislative strategy around this, because it is not an easy thing to navigate the state legislature. That 2019 bill that I mentioned, that also did a slew of other awesome things for the cause, was authored by Senator Colkhurst out of her district's actually Brenham and the surrounding area, but she happens to be, at least as historically for the last few sessions, she's been the chair of the Senate's Health and Human Services Committee. And so she's one that I think if we could get kind of on board with all this, not only does she's obviously very sympathetic to the cause, but she's got some skin in the game already, and I think we could easily get someone from her office and her staff to really talk seriously about formalizing something around this. And I say all this as I was doing my research. For anyone that's not following our state legislature as closely as I do, we are about to kick off another session. Historically, those committees tend to be very similar, and the folks that I've been looking at all did get reelected. So especially on the Senate side, I imagine we're going to be looking at a similar makeup. Things very much could change on the House side of things, because we do have a speaker's race that's got a big question mark, and could throw some variables into the strategy on that side. But here's just kind of an idea of some of the tools and resources that I've already developed in hopes of really kind of making this an easy venture for anyone that wants to throw their hat in the ring. We have a formal brief developed. Not only do I have a list of congressional contacts and some background information, committee assignments historically and the like, but I've also done a little research into just who do we have on both sides, the Senate and the House, that are healthcare advocates, public health, officials in their past life. And then I've got everything from committee calendars to talking points, examples of that prior legislation I mentioned, really trying to think of anything that could be beneficial into pursuing this. And these are just some of the stakeholders, you guys included, that I've reached out to say, hey, this is going on. I'd love to have your voice in the conversation. So everything from local political actors in public health, interest groups, and I've done some reaching out. Admittedly, I was a little bit behind my own timeline. It was only in the last couple of weeks that I've sent some communication over to Senator Colkhurst and some of our reps that we've worked with in the past. And so with that, I want to hear from the group. If anyone's interested, I've got a quick little, it's like 4 questions. It's what's your contact info? What are you interested in doing? And if we get a community lead, can I share that with them? And there's also an opportunity with this survey to not only say if you know of other stakeholders that should be at the table, whether, and I'm almost more interested in those that might have concerns with this. I've done a pretty thorough asset mapping of about 100 different organizations across mainly local and state, with some national groups as well, to say this is what we're working on, and we'd love to have you in the conversation. But that's not to say that I haven't missed any. So if there's other stakeholders you think should be at the table, or any other concerns or feedback you have for the cause, and then the follow-up's kind of playing it from there. We're going to kind of see what comes of this, likely do a follow-up meeting rounding up those that are interested, and go from there. So I'm going to take a sip of water. I encourage anyone, come off mute. Let me know what your thoughts are around it. Do you like what you hear? Did I leave you all speechless with my presentation? Trudy.
Hey, can you hear me?
I can.
Okay, cool. I work at the Dallas County Health Department, and yeah, that sounds really cool. But the only thing is that, like, DIS is really helpful, but we can't really even get enforcement on that sort of thing, like making sure that providers actually report the lab results or the treatment. So this just seems kind of like going in the same direction. It's hard to enforce this sort of thing.
Well, and I would definitely like to have conversation amongst the group around that, and back to that ASTHO publication I mentioned around policy considerations. That's one of the things that they mentioned, and in my brief I even kind of I compared this strategy with a couple others, because there are some jurisdictions out there that are considering more like punitive measures for those that aren't following the protocol. Because right now, I think that's one of the things is, does that, that we mandate this testing, but is there any punitive measures? Is there any enforcement behind those that aren't complying with the legislation? And again, I'm open to feedback. I want to hear more. I kind of went more carrot than stick with my strategy, and my thought was the enforcement mechanism behind that. One, it would cost. There would need to be resources. Someone would need to be monitoring it. Someone would need to be enforcing it. And the other thing that came to mind was, if we do something like that, are we stressing an already stressed workforce? And so I'm not saying I'm right or wrong, but it could be anything from like losing their license to fines, whatever. So yeah, I'm again, food for thought.
Yeah, that makes sense. Oh, my other thing was like, yeah, it's weird that you guys had a congenital syphilis outbreak when you did. It's just like, why? I know you said that was helpful. 2015 there was legislation. 2019 there was legislation, but I just wonder. I mean, there has to be, not that we can find that out because that's extensive, studying, but what caused the increase? Because that didn't happen in Dallas, that didn't happen in San Antonio, it happened in Houston. So, Texas is a big state, and it didn't. We all are suffering from the same issues legislation-wise, but like, why did it happen in Houston?
Well, and I have some thoughts around that, and I'll tell you, officially, our outbreak was around syphilis in general, but one of the things that we noticed was it was syphilis numbers, and it happened to be in folks of childbearing capacity in those demographics, those age groups, female assigned at birth, things like that, and statewide is where we're looking at congenital syphilis rates where they are. And so I've got some speculation on that, but again, it'd be speculation. I think the kind of the one easy thing to point to is our uninsured rate. Anytime you've got an uninsured rate around 20%, you're going to have folks that are going without preventative care, right? And so I know that's been a conversation as far as really ramping up things, testing, like opt-out testing in the ERs, because those are points that people that may not have insurance are engaging with healthcare. And I know we've done a lot of an education around that. But yeah, again, throwing that out there. And Julia, I know you've had your hand up.
Mm-hmm.
Yeah, thank you. So I'm one of the authors of that ASTO report. So glad to hear that it's being used. So two comments. I just want to respond back to the person who just spoke regarding folks still not getting captured and pregnant folks still not getting tested. Something we're seeing nationally. I'm not as well versed on Texas specific. But yeah, it is like folks who are just not engaging with healthcare system at all, whether it's substance use, insurance status, immigration status. There's a lot of reasons why folks might not be engaging in regular prenatal care. And then in terms of the carrot versus stick, I think you really hit it on the head. When we wrote the report, we did have those discussions and chose to recommend we didn't include really the punitive for a reason. That being said, another way that I've heard about jurisdictions approaching this is treating each instance of congenital syphilis as like a sentient event and sending letters to the health system or the provider, sharing information and sharing that did happen, which is obviously not a penalty, but just about increasing education and awareness.
No, I totally agree. And actually that is some of the amazing work that if you see, and I'm doing a bad job monitoring the chat while I'm doing this, so y'all keep me honest. But Jeanette Lopez Berlin and her colleague, Mayela, that they have been doing that. I will say, like, and that is important work that needs to be done, and they do it amazingly. But often we're catching it just after the fact, right? And so, again, we still need to be doing that too. But that's kind of where the more blanketed preventative approach idea sort of started to manifest. Was let's catch them before we realize we've missed that third trimester screening. But yeah, like all of this is, and Juliet, thank you. That amazing work with that. Seriously, that had more to do with the formation of a lot of my ideas than I ever gave y'all credit for on the front side of this. And Trudy, go ahead. And y'all, seriously, I want this to be a discussion. So feel free, come off camera. I'm done screen sharing, and we can make this a lot less formal.
Oh, okay. Yeah, that I didn't realize that I guess I got confused. I thought, yeah, that Houston had an outbreak of congenital syphilis, but you're saying it was actually just an increase in genital syphilis, and then it was childbearing age women, especially. So you were worried that could lead to increase in congenital syphilis?
Well, that was a lot of it, and I wish I had one of my data experts on to really parse it out. But again, like the congenital syphilis numbers have, you look at the rates that those have increased versus the rates of syphilis or other STIs, and the rate is far more dramatic and exponential than what we've seen for the others.
Mm-hmm. And so that was in Texas as a whole?
In Texas as a whole. Well, so Texas 2022, we were fourth in case rate and made up about, and again, we're big, right? So case rate controls for population, but of the 3,000 some odd cases nationwide of congenital syphilis, we were almost a quarter of those. We were a little bit better in 2023 that just got released by the CDC. And actually, I got links to those. I should probably put up just so you've got the easy, some easy references to that. But we were fifth last year, so slight improvement. But then you look at where we are for primary, secondary syphilis, and even gonorrhea and chlamydia, we tend to be more around the national average, like 19th, 20th, just right around the national rate. So it's not a stark contrast. Whereas, like our Texas's rate last year was 238.6 per 100,000 live births. The U.S. total average was 105, so we were more than twice the rate of the national average. And so that just to kind of give you.
And what was it then that in 2023 you guys were kind of like in a state of emergency? What was that? What was causing you guys to be in that emergency, and why are you no longer in it? What were you measuring? It was the amount of people who had syphilis, or the amount of congenital?
And specifically, we were looking at primary, secondary, and we also included early latent, looking at those numbers.
And so now those numbers are better.
They are.
Okay, cool.
Yeah, and I'm going to get these slides out to everybody, but that's one of the very first slides, the color-coded thresholds. Let's see here. I can get back to it real quick.
Hi, good afternoon.
Oh, sorry, go ahead.
Oh, hi, good afternoon. I just wanted to chime up. I'm Dr. Jeanette Lopez. I'm one of the epidemiologists for the congenital syphilis team. I just want to add up to what Elliot was saying. Actually, the cause why we started like seeing like a rise in congenital syphilis cases, it was because childbearing populations, they were not adequately treated, or maybe they were not like receiving the appropriate testing during pregnancy. Most of the times we encountered that it was because they were not going to prenatal care, or maybe they were like having issues like not having transportation or things of that sort. Also, I wanted to share that every quarter we're conducting case reviews on congenital syphilis. It's called the Fetal Infant Morbidity Review. And here we try to find, actually we select 3 cases in collaboration with the state, and then we basically will try to find missed opportunities and barriers that led to these women to deliver a baby with congenital syphilis. But in general, it's because missed opportunities during prenatal care or during that pregnancy that led to these moms to deliver the babies with this infection.
Oh, okay, that makes some sense, but I guess I just feel like I've harped on this before, and my personal opinion is just the test sucks. It's not a good test, and RPR is not specific enough, and it confuses a lot of people. So yeah, I hear what you're saying about, did they get treated properly? And then and when we look in thesis, a ton of times it'll say inadequate treatment. And when I get patients at the county coming in, they might have got 1 shot and they should have gotten 3 over 3 weeks, or they should have gotten, something like that. But the test is hard because you can't understand it half the time. Like pregnancy also messes up the test too. So then what are we really looking at? I mean, so in my opinion, not that you guys can fix it, but what would make me excited is if we could focus on advocating for an improved test, because we have better tests for every single other STD. Even HIV, and HIV is the newest of the STDs. Syphilis is like the oldest.
Right.
But we don't have a PCR. So if we don't have one of those, when I have patients, it's very shameful for them. They feel really bad, and they're always worried that they're going to give it to somebody. And I have to tell them things like, yeah, we believe you don't have it once you finish all your medicine, but your number might not go down. Like if you're already at a 1.1, it might not go down. And they're saying, well, then I still have syphilis. And it's like, not exactly. But even for me, I don't know. Even without medicine, the number can go down. So I feel like we do a disservice because we stigmatize syphilis by not encouraging to have a better test, which would be a PCR. And that even makes it hard for providers, because I work with syphilis all the time. And I can try to kind of get my head around it, but I can't imagine if a provider doesn't typically get syphilis, how they're going to really know how to stage. And so usually those providers just send the patients to the county, which is fine. But that puts a lot of stress on us to try to catch everybody. And, providers don't even know about the county half the time anyway. So I feel like that's kind of something that I think would help more directly with the problem.
Right, and I agree. We don't have a reliable test. Actually, this test has been used for the last 30, 40 years, and we're still having the same testing. I do know that there are some providers that they're basically ongoing or have an ongoing research project, like for example, Dr. Irene Stafford. They're trying to figure out if there could be like a better testing for the future. I know there are some works, on progress. That will be something exciting to know anytime soon, but I do agree, like having like a policy or pushing a little bit more to to get this testing. The thing with the treponemic and non-treponemic test is that we have to analyze, and sometimes the non-treponemic test, it might be triggered, actually it might be triggered by something else. So even for the same pregnancy might trigger the non-treponemic test to increase, like it's the RPR. And the reason is because basically this one, it's like looking or something that is triggering the cardiolipin, that we have cardiolipin in all the cells in the body. So the thing with the treponemic one, which is the TPPA, a patient will remain reactive for a lifetime once they become positive, because basically what it's stating is that the patient was in contact with the bacteria. So yes, I agree that we should push a little bit more to get like more reliable testing for syphilis.
And Dr. Jeanette, this is actually Elliot Davis posing as Austin now. I'm sorry, y'all. My computer decided to freeze up at the most inopportune moments. But thank you for covering for me. And Trudy, I hear you. And I don't know if you saw that Julie just dropped something in the chat. That is a federal priority. And there's a great little resource link to the strategic plan right there. And I also wanted to comment, as I'm playing catch up here, Dr. G, I see your comment as well, and I totally agree with you. One of the agencies that I actually reached out to was the Texas Alliance for CME, for that very reason. Because anytime we talk about doing a mandate, if there's not a funded solution and way to implement it behind it, but I hear you as far as there's got to be an offering for that too. For this to really be a viable thing. And Jeanette, I think I owe you dinner for covering for me on that one.
No, you're welcome anytime.
Any other thoughts, ideas, concerns out there?
I just wanted to add that it takes a village to fight back syphilis. This is something, actually, I'm just still in this phrase from a nurse practitioner that one time she called me and she was trying to inquire about information about this mother that delivered a baby, and they were suspecting the baby has congenital syphilis. The thing is that we all have to get, unified to try to get like better solutions. So we have actually a very concerning, I'm not gonna say an emergency, but it's feeling like an emergency, that we're still seeing babies being born with the infection. And it's not only the testing, it's not only that maybe the mothers are not having good prenatal care, but sometimes even if they do have prenatal care, they're not being tested or screened according to the Texas Health and Safety Code. Sometimes I do know that providers, they do like at the first prenatal visit, then they're supposed to do during the third trimester, specifically within the 28 28 and the 32 weeks, and then at delivery. This helps because it's going to help us like to screen more and have some time to catch the infection, and then basically treat that mother before it's too late. So I'm seeing always syphilis as an iceberg. So it has several compartments that we need to address, not only the testing, not only the provider education side, or maybe the treatment, but at the end of the day, I think like pushing from legislatures or something like that, like to push more for good testing or more resources, that will be a game changer.
Do you guys have any advice? Because Dallas County, I really like working here. I think that our health department's really good. I worked for the state, and I worked in a small county, Kaufman, and it was like eye-opening because it was really hard. I was the only nurse, and I was trying to take care of people within 3 counties around me, which is impossible. So, I would end up sending them to Dallas and stuff. Or I've heard that there's other county health departments that are just smaller. They just don't have as much resources. So Dallas County is special that way. But I feel like a lot of providers also just don't really like talk to us. They just send patients to us they never really ask that. Like the providers don't really know what they're talking about. Like they'll tell the patient, yeah, I gave you 14 days of doxy because you have a syphilis rash, but I want you to go to the county and get penicillin shots as well, or just different things like that. Or all they do is an RPR test. They don't even do the treponema, and it's a 1.1. So they want the patient to get treated because of an 1.1. They don't do the treponema testing. They don't do confirmation. And I feel like we're in a silo, like we're just off by ourselves, even though we're supposed to be supporting the community, but the community doesn't talk to us, and we don't know all the different clinics in Dallas because it's so huge. So do you guys have that issue, or is there someone you've deemed to be your resource to help you get the word out to the different clinics that they can talk to us and speak with us?
So in our experience, we basically, when the syphilis outbreak started, we started noticing the same kind of issues. So we started preparing different collateral educational materials, and then we started going to those facilities to provide that provider education, encouraging them first on the Texas Health and Safety Code for testing. Secondly, on the management of the patient, because we noticed also that they were using the RPR without the confirmatory test, or they were using, for example, the confirmatory test, the FDA ABS, which gave a lot of false positives. And we started to basically those providers that we were seeing, they were reporting, and we started noticing some issues. We were basically going to them. It's like a strategy that it worked very well for us, because then at the end of the day, it just kind of built like a trust between the health department and the community providers. And we're still working on that, and we have grown a little bit, but I think it's something, I don't know if you on Dallas you have something like that, but it had helped us a lot.
Oh, yeah, that's really encouraging. And what department were you guys utilizing? What staff was? Because I know everyone's short-staffed, but did you guys use DIS to do that, or were there nurses?
No, we use epidemiologists. Also, we had some of the DIS doing also the work in surveillance investigators.
Okay.
And not only that, we also created a toll-free line for providers in case they needed a record search. And then we posted that on the website. So they were able to, if they were Googling or looking for a site to kind of, look for information, they were able to find that. So this provider line, basically what we were doing, or what we are doing with the provider line, is that we're conducting record search. Sometimes they call, most of the time, from labor and delivery units to make sure if that mom was treated or not. And that kind help them to get a better idea on what to do for that baby, for example. But also we have received calls from for example, providers telling hey, I have this patient, now she's reinfected, what should I do? Is there any way you can help us? What about the partner? They have even reported to us partners. So these communication pathways, I feel they're important, and mostly when we spread the word out, it helps a lot. In it's kind of helping with one of the issues that we are seeing with the congenital syphilis portion as well.
And you did all these things, like once you had that emergency situation, that's when you posted the toll line and started visiting the problematic clinics and stuff?
For example, with the provider line, we actually like started developing that before the outbreak. But then once the outbreak happened, we saw that it was like a good opportunity to spread it more. So we kind of enhanced it with the outbreak. Same for the provider education. We were doing it, but it was at the beginning, it was only by phone calls. It was a little bit hard because sometimes it was very hard to get with the providers and talk to them. But once we started like going out with the materials, with even we were making appointments. If they were not able to schedule with us, we were basically go there and hey, we need to talk to you when it's a good time. So at the end of the day, like it helped. But I feel the outbreak, the syphilis outbreak response helped to enhance all these resources that we had actually.
Okay. Do you have like the number one or a few things that you think personally, like, oh yeah, that's really what helped the decline in the statistics, when you wanted to see a decrease? Like what do you think really helped you the most?
I think like going to them as a support and not as pushing them like, hey, you're doing this wrong or you should not do this or that. I think like making them see us as a support was good, for us in the outcome at the end. Um,
Okay.
we encountered providers that they even like saw us as the police, like why you're here. I'm the provider. We know what we're doing. And then it was like hard at the end, but then at the beginning, I'm sorry, but then basically once we started like showing them like, hey, this is what's going on. Like for example, I can tell from one OBGYN facility that they were reporting a lot of cases that they were like basically giving probabilistic congenital syphilis diagnosis. So we went there and we said like, they were actually one of the first providers we visited, like, hey, we had this issue last year. You had like this amount of congenital syphilis cases. We need to talk to you. What's going on? We're seeing that you're using this test. We're seeing that this is going on. And then basically they understood, and they understood that we were not there like just to, push them or enforce any law or anything like that, but they were seeing us as a support. And even now we're receiving calls from them like, hey, I need to research this patient. Can you help us? So I feel like building that trust with the provider community, it's basically imperative to help on this point.
Oh, that's really encouraging. Thanks.
You're welcome.
Well, and I'm going to interject, and y'all, Jeanette had no idea I was going to lean on her to do so much of the heavy lifting, but you've been doing it so beautifully. I've been letting you go. But I could tell you from observing her work and her colleagues' work how appreciative the providers are, because she has taken that approach, and they've made themselves very available as a resource. It's been very much a we're in this together kind of mentality. And Trudy, to your point, and I hear it in your voice, I hear how much you care. And yes, public health has never had all the resources we need, right? And so again, there was a lot of that behind the construction of this idea. But to your point, to Julia's point, and to one of my my new contacts that I'm getting to know, Miss Stephanie Sword in the chat from Save Texas Moms. If I could wave my magic wand and everyone has universal healthcare, that would be the best solution, right? Because I realize one of the huge downsides, one of the huge blind spots to what I'm proposing is for those that aren't interacting with the healthcare system, this does no good. So this is not the entire policy solution by any means. It is a little bit of it, and it's kind of what I see as the low hanging fruit. But there's a lot more that we got to do, and I know everyone that's hanging on for this portion is an advocate for that. However, they see the solution being. But we do. There's plenty more we got to be doing. But thank you for what you are doing, Trudy. Again, I can hear it in your voice how much you care.
Yeah, thank you. That it's just you can get burned out when you keep doing things and the entire system's against basically the patient and you, and the system doesn't mean to, but the system's impersonal, so it doesn't have to deal with face-to-face contact and explaining every day why, even though it says you're positive for syphilis, you don't have it. I mean, that's just really discouraging for patients if they now have a mark and that makes them feel dirty, the same way people feel like stigmatized about herpes. Like, I don't want that. I want sex to be pleasurable and fun, and it can't be that way when we have a test that is confusing as heck, and that makes it hard for even the providers to feel confident. That just feels like negligent, like you said. So I guess we just need to be patient, but keep doing what we can do.
And keep being a resource to each other. And that offer goes out to everybody on this call. I dropped my email in the chat. I'm going to do it again. I know it looks like I'm Austin, and y'all, thank you for rolling with the punches. I do have a love-hate relationship with Teams, but I want to continue this conversation. And Ms. Janice, I don't know if you can drop the link to the survey in there one more time for me. We are at our time, and thank you all so much. This was a long meeting, I know, but both things were very important to me, and I was trying to squeeze them both in. But do please use me as a resource. I want to keep this conversation going. Let us know how we can support you, and stay tuned for what's to come. And I'll hang on for a second so long as Austin doesn't mind me continuing to steal his computer. If there's any lingering burning questions, but I know it's been a long 2 hours, and I very much appreciate you guys taking your time to do this. And to all my colleagues